So,
to
Dr.
some of
Abhijit, I would officially like to welcome you.
the.
I really will wish that you should be able to come on better days to see our campus. Uh, we have on our own have developed a good research clusters, and cancer is one of them. There are five, six very bright people who have joined. Abhijit, Amit has Vaibhav joined.
Vaibhav, I have to check.
So Vaibhav is another person who just joined a month ago, and he did his PhD from MD Anderson,
Oh, wow.
and quite a lot spent time in Lausanne University in Switzerland.
Very good.
He just joined. So we got five, six very young, dynamic investigators. So I thought it's very appropriate to show you the excellence, at least in imaging, what you do. It's really remarkable what you have been doing in the institute. So I really welcome you and appreciate your time. And I hope we'll have a good, of course, interaction of 1 hour. So Amit, I would request you to formally introduce the speaker, please, so that.
Okay, good evening and welcome all. And on the occasion of this World Cancer Day, MIT AIV, MIT Institute of Biotechnology is organizing a webinar, and we, Dr. Abhijit Day has obtained his PhD degree from BHU, and then he joined as a postdoctoral fellow in the CCMB Hyderabad, and then moved to the USA, Los Angeles, to complete his second postdoctoral fellowship. And there further he worked as a research associate in molecular imaging program at the Department of Radiology, Stanford University, with Professor.
Amit, interruption. Abhijit, where were you in Los Angeles?
I was actually UCLA. There was
Oh,
a
UCLA.
new institute of Department of Pharmacology, that is Kramp Institute of Molecular Imaging. So it is one of the
Oh,
three
because
imaging
I
centers.
was in USC Medical School. It's a
Oh, okay.
very big school, medical
Ah,
school.
yes, yes.
I thought maybe. Okay, go
So
ahead.
that is on the downtown side. I was on
Yes,
the,
yes,
yeah.
huge, huge. Yeah,
Yes, yes.
it's a big hospital.
Okay.
Sure.
Yeah.
Dr. Day has published over 45 research articles, reviews, and book chapters, and hold one US patent. Oh, and his invention on bread technology was granted patent right from the US Patent Office and is licensed from Stanford University, USA. He has experiences in both academic research projects as well as academia industry collaborative projects also. Currently, he works at the ACTREC, Navi Mumbai, as a scientific officer, and also affiliated with Homi Bhabha National Institute as an assistant professor and a visiting faculty at the Department of Biotechnology, University of Pune. And there he teaches molecular imaging applications. And today he is going to talk about the applications of the novel gold nanostructure for photothermal therapy in cancer. So I also want to know about what is photothermal therapy, and let's hear from Dr. Day. Welcome, Dr. Day.
Yeah, thank you, Dr. Amit and Dr. Rajendra Prasad ji and Chandamani Patak. I know for a long time. He's one of my juniors since my time in the PhD. Later on, he was also part of Gandhinagar for a long time, where I met him last. It is really, really an honor for me to be part of your program today on this very occasion of World Cancer Day, for which this webinar you have arranged. So you know this. If I put my slide on the presentation mode,
Yeah.
just allow me. Yeah. So I hope all of you see my slides well.
Yes.
So before I come to the topic, let me introduce my institute. So this is the Tata Memorial Hospital that you know of. It's one of the biggest cancer-focused hospital, dedicated cancer hospital. And this is the new Homi Bhabha Center, where it's all about patients there. And it is located in Mumbai. And in the Novi Mumbai, so when you get past the bay and come to the mainland, and this is the Novi Mumbai, where this is our active campus, and this is the building in which I am. My establishment for the lab is there. So the lab, talking about the lab means, Amit has already introduced. Yeah, so the lab is focused primarily on imaging, and we use imaging which is for the purpose of therapy evaluation primarily, and where we are actually involved with multiple types of different therapeutics. So talking about the therapeutics, if I may allow, I'll proceed to the next slide. And so, in mission on today's day means, the cancer is still a very, it's a disease that is causing the highest number of death, alongside, the cardiac infractions and things like that. But in the COVID time, we have experienced the number of deaths that is happening, but that number is still very, very low when it actually gets compared to cardiovascular disease or cancer disease like cancer. So it's a significant, and the war is going on for a long time, but still we haven't been able to. We have come across some part, overcome the challenges, but then we also face new challenges. So as I go forward, you will get to hear from me on this again and again. So let me just start out my topic. So, in cancer, so it all starts from one bad cell in a pool of cells within a body, in a part of the body. And these bad cells then rapidly grow, and form a big mass of cells. It gets spreaded elsewhere. It draws blood vasculature. And all of us, and one major chunk of research effort that goes is on the therapy, where we like to see this reverse route, like the last part of the video that, as you could see, that we want to shrink this growing bulge into the reverse path. We want to show the reverse path so that that bulk actually diminishes and the problem goes away. So this is, in one word, if I have to describe cancer, so this is what I would get started with. So it is still, as I was saying, so it is still a cause, the leading cause of death, and it starts from one cell. And if we, very simplified way, from Chandamani, what I understood is the audience could be very diverse, starting from early stage students to advanced level students as well. So I'm just trying to tell you about the disease in a very simple word. So if I have to tell it what cancer is, so I see it as a change in the cell function at the early stage, and over a time that brings to an outcome, which is a change in the structure. And what are the structural functional change early stage, like what I called as a bad cell in the previous slide? So they are like one cell, because it has acquired some set of genetic characteristics, its molecular functions, the implication that comes, that change the cell's proliferation, cells' ability to die or not die, and basically the inhibition of cell death, the activation of invasion and migration. Cells become smart. They can actually move from one place to the other, like this cartoon schematic shows here, and then drawing blood circulation in the new spot, and again grow there and spreads elsewhere. So basically this change in the cellular parameters, the functions, that is in the one cell stage, and over the time, these one cell become multi-cell, and that brings in a change in the structure. And therefore, a mass that was not there in the place for normal organ function, now because of the mass, there are a lot of different symptoms that started coming, like pain or something else, and which is caused that actually the uncomfort, brings in the uncomfort, and that's where we go to the hospital and get, when it is found that there is cancer, so that is pretty much a late stage. So this is the challenge, and this is where the world has been attempting that how we can actually overcome cancer is not by if we can only address things in the late stage. We have to address things in the very early stage. So there are different processes for that. People have been deriving. So this is, in one word, it is called early detection of cancer is very important aspect. So where people who are focused on diagnostics development, they are actually focusing on developing strategies which can detect cancers in a very early stage rather than late stage. So talking about the therapy, which is where my talk's focus would be today. So there are, the standardized therapy. So if you think about historically, so in a very early stage of human, era, so when there was not sufficiently, the medical systems were not sufficiently grown. So it was very crude applications that was there. That is the card-borne poison, right? So either if it is on an appendage, just cut the whole appendage out so that the disease is out of the body, and otherwise, you poison it or burn it using different mechanisms. So now with the modern medicine, so these are the three main versions that still is the hope for cancer when it happens to anybody. So the surgery, the radiotherapy, the chemotherapy, and it is the card, burn, and poison is the form of card, burn, and poison in the modern world. But all of these, and it is not that it is a single modality that is being applied. It is oftentimes, it is actually, in many cases, it is the radiotherapy followed by a surgery, or a chemotherapy followed by a surgery, or even a combination of radio and chemotherapy, like neoadjuvant chemotherapies and so on. But these, in spite of these, become our only hope to cure the disease. These are not there are a lot of problems that we also know with so many years of practice that is going on. We still know that there are a lot of the challenges that it causes, and there are a lot of issues that are actually I have given on the right-hand side. So these are different side symptoms because of the toxicity issues or even the deformations due to surgery, surgical interventions and so on. So basically that, so in one word, if I have to say that none of these procedures are really safe. So there are a lot of discomfort that is involved. But we always try, so current medical practice always try to circumvent how to keep these toxicity issues minimal, so that that refinement protocols we are constantly evolving. And this is one area where nanotherapeutics has been delivering a lot. And there are different formulations that can minimize the amount of drug to be applied, and its kinetics and so on, and its direction. We can attempt delivering the drug towards the disease site only, so that the toxicity effect on the normal tissue organs are less. So this is where nanotherapeutics has been delivering. But as we now deal with these therapeutics, so there are two concepts. There are actually many concepts, but I'm just narrowing it down to two major concepts that we can think of. And one is called an inherent drug resistant cancer, and the other term is acquired drug resistant cancer. So basically, you can think of that a bulk of cells, which is a tumor or a cancer, and when it is being treated, so one school of thought says that there are some smart cells that are hiding inside that mass, and when I'm treating for this, the major mass of cells will be killed, but this mass of cells do not respond that well to the treatment that we are applying, and so they survive. And then this brings back the mass again in a new form. So that's a continuation of cancer or a relapse of cancer. And this is where, so basically this concept shows that there is a set of cells which are actually inherently resistant. So they were never affected by the treatment that you applied, and so they brings back the disease in the later stage. Versus the other school of thought, it shows that the acquired drug resistant cancer. So here we can hypothesize that perhaps the whole mass is equivalent, and then we apply a therapy. And because of the therapy, the therapy procedure itself caused a lot of changes in different cells in different way, and different mutations caused, and then there are different species of cells that forms. So where the major mass goes, but few cells that could escape this treatment are now a new species or new beast, you can say. And these cells will bring back the disease. So these are the two different causes, and I hope I could clearly deliver this. And there are different terminologies that are being used. There are someone called the therapy escapers, cancer stem cells is the most common term people use. There are metastatic cancer cells. They're also equivalently used. And someone just casually say that they are very smart cancer cells. So the field has evolved in the area of therapy, and the problems that are really persisting in the field, in spite of we have developed a lot of targeted medicines and so on, but still we see that tumor comes back, tumor relapse. So resistance to the therapy is always the case, be it a radiation therapy, be it chemo drug therapy. So resistance is always around the corner. And this is what is the challenge that the current level of research in cancer is primarily involved. And this paper actually shows, published in 2017. So, earlier days, Hanan's paper in 2000, around 2010. So it shows that there are certain characteristics for cancer, which is how the cancer cells are different from the normal cells. But now that the research aspects have bring us a lot more knowledge and how cancer progresses and all. So now the understanding is the differentiating the resistant cancer cells from the cancer cells. And this is where this review article actually showed this new schematic, where at least there are some 6 parameters in anti-cancer drug resistance area, where there are parameters such as the drug target, altered drug target, the drug pumps failure, detoxification mechanisms that the cancer cells adopt, and that is how they can evade these different drug treatment that is being applied to them. And of course, in all that process, the apoptosis, because the cell has to survive, so they are now thriving to survive even more when the assault is given. And so the reduced apoptosis is also a parameter altered proliferation. So cells are even more proliferative in nature than the normal cancer cells, and increased DNA damage. So a lot of these drugs or radiation therapy, it causes actually the DNA damage. But cancer cells has the DNA damage repair machinery, and that repair machinery become very strong and very dominant character, so that they can quickly, whatever damage happens, they can quickly repair it and make the cells to the survival pathway and keep it floating. So this is how the understanding has grown over the years, and this is where the challenge is. So if we just now, if we thinking about this whole aspect of this growing problem in the area of cancer, if we have to think, then perhaps this is the analogy I can give you best, that we are trying to catch a python, and when I'm holding its head tight, I'm trying to get it under my control, and it is also coiling my arm and trying to get released. So this analogy perhaps tells you that, you know, what cancer is, how cancer can be really a smart entity, and how it is making our efforts of so many years, that it is still being a burden for the human race. So with that brief introduction, I now want to tell you about one aspect of research that is ongoing in my lab. And this work is primarily with a team of scientists. Professor Rohit Srivastav is the main in IIT Mumbai, and my group. So we have been dealing with this aspect since last 7-8 years. And we have a very strong collaborative effort that has gone through on this area. So I thought of talking to you about this aspect of new research, because, you know, just today morning on Global Cancer Day, there is an editorial in the newspaper that says that for a country like India, you know, the lot of the cancer, I mean, the moment the cancer happens, it is like, you know, somebody's house, it is under fire. So it will consume your lot of money, and it's a disaster in many aspects, both financial, mental, as well as every other aspect that the patient goes through. So it's a very big thing that we all encounter in our society, and this is where the India should focus of bringing out the low cost but efficacious therapy alternatives. And this is one aspect that myself and Rohit's group has focused. I am, as you know, as I was introduced, I am more of an application biologist. The material, this research also involves a strong material design, which is primarily has gone through in the IIT Mumbai lab, in Rohit's lab. So if I have to introduce this in simple terms, what is photothermal therapy? So the photon triggered thermal, so energy conversion principle. So how it happens, so there are a lot of these dipolar oscillation kind of material metallic elements, which in a nanoscale, so they are, you know, this collective oscillation conduction band, and it actually oscillates against its positive charged metallic core. Okay, and because of this oscillation, the heat generates, it converts into the heat, and that is what you can actually achieve. This heat can actually, it's like a school child kind of an experiment you can do. So this video, this is a little longer, so I'm not running, but I'm just showing the end stage, that when you put just blank, meaning just the paper, the water, which is the solution where the nanoparticles would be, and the nanoparticles when we dropped it in another piece of paper. And then when we we are combining it with the laser, which is actually these materials are tuned to that particular laser radiation. And when we irradiate these spots, you can actually see the end stages that the paper can burn. So these are kind of experiment we all have done in our school age, early school age. You know, the sun's light through a magnifying glass, you burn the piece of paper. And you can also do this. So the heating that cause, it is very local in nature, but it is significant enough to burn even the piece of paper. And when we do it in a monolayer of cells, which is the live cells, the cell which could be a normal cell or a cancer cell or any type of cell, and in one go, the laser beam, the radius, you can see that it is lost. The cells are lost momentarily. So it's a very intriguing thing that when we saw after designing our very first material, which is lipose AU, which is what not I'm talking today. I'll be more focusing on two other materials where the material is actually polymer in nature in the core. So before going to the material itself, so this is one such material that is we named as tocophotoxyl. And this material has a PLGA polymer core, and on top of the polymer, there is gold particles, gold nanoparticles of around 3 to 5 nanometer. They are actually coated all around. So it is like, you know, I'm a Bengali and a big fan of sweets. And I'm sure a lot of you in the audience are also Bengali sweet fan. So if you have ever entered in a Bengali mithai shop, you might have known of a sweet called ras kadam or kheer kadam. So there is a central core with a more juicy, and then there is a layer of sandy rustic coating on the top. So this is the same design almost here. So here the coating is, the core is the PLGA, and then there are gold nanoparticles are coated on the top of it. And this is how we can actually tune the material to either 750 nanometer, which is NIR laser, or 915 nanometer, which is also even far red, actually near IR laser. So what I'm showing here is an IR camera image of, you know, which can actually detect through the temperature that it generates. So when we put it, only the laser is added for 2 minutes or 4 minutes or 6 minutes. And when it is added to just the PLGA, there is no rise of temperature that happens. It stays pretty much within that 35, 37 degrees centigrade. But when it is the particle that is the tocophotoxyl, and which is when irradiated with the same laser for 2 minutes, 4 minutes, or 5 minutes, 6 minutes, we see the temperature goes up to about 53 degrees centigrade. Versus 915 also it goes, but not to that extent. So this material turned out to be the best material to be used, which sufficiently generates enough heat that is good enough for treating biological entity. And that being said, I want to tell you what we need to understand, that what is actually important, what temperature is critical to achieve. So if I show you through the schematic, I'm trying to explain you that think about yourself. You know, the normal body temperature 37 degree when we feel fine and we are normal, we act normally. But when we are catching a cold and catching a fever, or we are getting exposed to like areas like Rajasthan deserts, so it's the same thing. So the higher the temperature we feel, so at the lowest, like up to 41 degrees centigrade, up to 105 degree Fahrenheit or 6 degree Fahrenheit. So there are some changes which is tolerable, and this is a stage called diathermia. But the moment we get past 43 and above, we started a lot of irreversible changes started coming in, and that is actually the hyperthermic effect. So hyperthermia is a long practiced in the radiation oncology area. It's a long practice treatment for cancer and many other diseases as well. And but when the temperature passes 50 degrees centigrade, it is impossible that if, even for shorter period of time, the changes that happens are irreversible damage, and that actually can cause death. And this is exactly is the principle what we wanted to follow. And this is where the PTT is very attractive to me, because it is a photon triggered. So now it is a triggered. It is not the hypothermia can be done through whole body exposure or local exposure, but that is not a that will still, like, if even if I have a small spot to treat with, and I have to wrap the whole thing, my whole hand, so the whole hand is actually exposed to that treatment that is going on. So here, through wherever I point the light, only that area, the local heating happens, and you will see the effects in a later stage of stage. So I'm just giving the how the biology changes and what sort of change in the biology that brings down the PTT to make it effective for cancer cell death. So these are the two basic material that I'm going to talk about. One is in the terminologies that I'm using is AuPLGA or tocophotoxyl, and AuPNVCl or thermophotoxyl. So these are the two trademark names that we have actually also filed around these two materials. The design is the same. Basically, in here it is the both are polymers. This is PLGA FDA approved polymer. This is a PNVCl, which is poly N-vinyl caprolactam. So this is a thermolabile polymer, and I will explain you why this polymer also we have started designing. But in either case, it forms the polymer core, and then we add some gold seeds, and then those gold seeds get expanded under the exposure of the precipitation of chloroauric acid and ascorbic acid precipitate. So as the gold precipitates, so that layer thickened. So you hopefully this helps you to conceptualize the Ras Kadam Khir Kadam suite that I has been referring you to. So talking about the PLGA, so this is the size measurement through ACM as well as DLS, the dynamic light scattering. So we got about a particle that are about 140 nanometer in size, and they are tuned for either 750 or 915. So here the core to cell ratio that determines at what wavelength it will be actually tuned to. And we have made two different versions of thickness of the gold layer, and that's how they are of two different laser tuned. And the one of the aspects that I put it in the red is that the laser that we are using is a very, very low powered laser, and that laser has no harmful effect as such. So primarily all the different skin clinic, there are a lot of laser based treatment nowadays available. And most of these lasers are like at least 1 watt or 2 watt, if not more. So our laser is very, very low powered, so that just from the laser exposure, we see very less effect, very less toxic effect. So what we are showing here, the data shows here is the tunability of 750 nanometer at peak. And that is a material that generates a very nice heating. Within just 5 minutes of time, it can reach to 50 degrees centigrade from the room temperature. So with that being said, the other material that is the PNVCl. So this is, as I was mentioning, this is a thermolabile polymer. And the reason why we wanted to is one of the translational point that we want to keep in mind is that, whenever an exogenous material has to be delivered in human body, as I am part of the hospital at Ast Institute, so I hear these sort of questions that how long the gold particle will stay in the body, how long, what is its kinetic, how long it will do, and what it will do to the human. So the ethics, so there is about always a medical, the ethics is a very big principle that has to be followed, that in the name of therapy, we cannot make harm at least. So that has to be ensured, that is the ethics. So that is where all these questions comes, that gold particle is an inert metal. So if it stays in the body, how, what it will do. So you have to then answer 100 questions. So it is better that in your design, material design, if you can ensure that the metallic particle is living from the body beyond the treatment. And that is where we thought that if the core material is thermolabile, so now when we shine the laser on the top of this material, the material heats up, and that heat itself will melt the core. And as the core melts, only the gold nanoparticle seeds, they will actually get eliminated through the kidney. So the kidney elimination is a faster kinetics, and so that ensures that the exogenous material that you have delivered for the treatment, that is being renally cleared, meaning it has left the body in a faster manner. So that is where this PNVCL product we have added. And we have actually added the PNVCL, its LCST is very, very low. So by 1:4 ratio, we could actually set it out to 43, so that it is above the body temperature, that is 37. And and when we trigger it with the laser, so then the temperature definitely goes beyond 45, 48, and at that point, so the max temperature that it can reach to 49. So at that point, definitely all these materials, the core material will actually melt away. And I will show you the results. Okay, so with that being said, that the first thing we wanted to check is the efficacy of the material. But before that, its biocompatibility is also very important, which is what has been tested in different mouse fibroblast cell lines, and where you see that absolutely no toxicity just from the material, even with 125 microgram per ml concentration. So when that concentration brought in the context of multiple different cancer cell lines of different sources, so we see that the materials are also biocompatible, so they don't do any harm for the cancer cells. So as only when the laser that we mix up with these, and only then the treatment effect is effective, and it kills more than 80%, 90% cells, and only leaving 10 to 15% cells survive in that cell. So that being said, another area is the challenging area is, like, as I was mentioning, the resistant cancer. So these are normal cancer cell lines versus we have also now different radiation and chemo resistant cell lines. And those cell lines also we exposed, and we saw that the same treatment can be equally effective in those. So because this is a mode of a physical treatment, so this treatment do not see any bar in terms of treatment of normal cell, or a cancer cell, or even a resistant cancer cell. We have also tested against different very highly selective drug-resistant cancers for ovarian cancer in collaboration with Dr. Ray in our institute. So again, we see that similar efficacy there. So this is in culture. Now, when it happens to the in vivo scale, how it is, and look at the simplicity of this procedure. So here, the tumor, which is visibly differentiable, and there you inject and palpable, you inject the 125 microgram of our gold nanosphere, and then you excite it with the laser, and just right after the laser switch is off, 5 minutes exposure, you see that complete dehydration. So the diffusion, high diffusion rate, that is a parameter. So it's a dried mass, just like that. And the following day, that mass is gone. So it is like a barn wound that is living in place. So it is such a quick, such a prompt action that you get right away in the in vivo scale. So in another set of tumors, so we actually, after 1 hour, we take out the tumor and we actually cut it open, slit it open, so that we see how far and how much the extension has happened, extensive treatment has happened within the tumor core. So it's a big size tumor, about 1 centimeter. You can see from the angle of the laser, because the photonic photons has a limitation to penetration, depth penetration in the tissue. And so that's where up to which it can penetrate, only that area is actually burned. And the other side of the tumor is still good. So we have analyzed these through the, detailed histology has been done. So the burn area is this, but there is a neighboring area which is unaffected, and there are further areas which is again unaffected. And this is the skin which is covering the subcutaneous tumor. Okay. So recently, another piece of work extending that validation, because this shows about the precision of this therapy. So we thought that we will use Raman spectroscopy here, because Raman scattering has it's the natural signal, and the scattering effect from different moieties that are in place in the body. So they give different peaks when it is being excited. So what we see is that this section, so where we have the core burnt area, then Raman scatter can actually map. In the map, it shows that there is a transition area and there is a far area where there is almost no effect. And these are the different peaks, that these 6, 7 peaks I have marked here. So these are actually characteristics of significant moieties, like the protein, the CO stretching of protein, or the CC stretching of lipids, or even NH bonds of the DNA, between the guanine adenine bonding. So these are the different peaks that are characteristics and well mapped for Raman scatter, and we see that either a transition that is happening from the core area towards the non-treated area, and this work has been communicated, not yet published, but this is one of the recent results that which is describing that how precise this treatment is. It's almost like a scalpel, in the surgery. So we can also use this as a surgery guidance or pre-bulking before the surgery can be done. So overall effect in the preclinical scenario, that is what is being described on this. So in this case, you can see that the control or the treatment, meaning only the laser is exposed, and there is no effect that is seen. The tumor continues to grow. But when it is the tumor is injected with the metal and then excited with the laser, then the tumor is absolutely gone, and it has been followed up for up to several months. And we see that the tumor, for when it is treated with the 750 nanometer tuned material, the tumor never came back. But 915 being less effective, the tumor could come back. It was minimized, but then it came back. It was minimized, but then it came back quickly. So then at this juncture, actually, the students who are involved on this project, they started saying, sir, we know how to cure cancer. I told, no, cancer is a lot more complicated disease. So let us challenge this. So this is where actually we started exploring the therapy-resistant cancer. And this is just one example of a cell line that we established of radio-resistant breast cancer mouse cell line. And this is the baseline cell line. So both cell lines are labeled with a reporter gene, and this reporter is an indication of live cells in place. So when we actually make these are breast cancer, mouse breast cancer cell line, and when we place this cell inside the mouse mammary fat pad, this is the day 0 when we just injected some 100,000 cells, and within 16 days, it formed into a big size tumor. And for this also, this tumor is also very big size, but within about 32 days, the tumor actually, it has started necrotic, it has started spreading elsewhere in different organs, and that is even more on this. So this is, we call this as aggressive. So this tumor is a lot more aggressive than the baseline. And this is where I challenged my students. So you can see that at the harvest, means at the end point, we actually measure organs. We have isolated from the control as well as the radio-resistant. And you see the number of tumor foci on the lung, brain, pancreas, bone, liver, everywhere it has spreaded. And the tumor metastatic small tumors, they are a lot more of higher growth and less the frequency is also high, as well as their growth is also higher. So they are definitely a lot more aggressive. And this model, then I asked them to let us try our PTT and see what is the effect that is happening. So if we don't do anything, so this is the control arm where the 41 FR cells were allowed to grow, and they spreaded all across in different lungs, liver, and everything within 32 days. But in the treatment group, where the localized ones, the good size tumor is attained, then we start doing our treatment, and on day 22 and day 23 with one booster dose that we do, and we see that the tumor mass absolutely shrinked. And essentially what it gives us is something that we need to realize, is that it's the survival benefit. So it is actually now this mouse, if this mouse we have to sack because they have attained their last stage. If we don't sack, it will die. So within 35 days, versus now when we do the treatment, at least this mouse can survive double the time that they can live otherwise. So we could not stop metastasis, like it has metastasized here to the lung. Metastasis we have also encountered at the end stage in the lung, liver, and so on. But by treating the primary tumor well within time, we can get enough time. So if the mouse was surviving for 35 days, now it can survive for 70 days, which is a big survival benefit. So most of these, the clinical trials that goes on, so where people talk about, the addition of 2 months life or 1 year life or 5 years life, here we can actually give a doubling time than the expectancy. So which I think is a big gain, and with such a simple treatment modality. So talking about the translation, there are a lot many things that we have to figure out. So we have done a lot of that very thoroughly, but I'm just giving you a glimpse for the sake of time. I cannot bring in all the different data, but this is the primary data that because the exogenous material, how it gets distributed inside the body, different major organs have been harvested and checked for ICP-MS. Mass spectrometry, so because this is metallic particles, so we can do ICP-MS and verified what is the actual quantity in different organs loaded. And we checked for the histology, the full spectrum of the biochemistry, the liver function test, kidney function test, heart function test, as well as the full hematology. And all of it shows that through the treatment, we don't see drastic difference in any of these normal functionality. And Am I out of time?
No, you can continue.
Okay, I'm almost close. So just a couple of more data. So another version of the biodistribution study. This is another aspect of imaging, that is near infrared imaging, where we have actually used the IR780 dye. We tagged it on our particle, and we have also made a folate receptor targeted particle and tied with the dye. And then we are trying to see in the tumor bearing mouse how these moieties can accumulate. And what we are trying to figure out through the imaging, use of imaging of NIR, is that what is the window, time window, how long, how soon it accumulates in the tumor. So we see that 4 hours onward, the contrast started building, meaning there are sufficient materials started accumulating in the tumor, and it goes to the peak within 12 hours, and then it stays there for at least for the next 2-3 days. So this is a good enough window. At that point, we can just excite this mouse with the laser, and we can actually, so this plateau space, we can actually excite the tumor area with the laser, and we can see the effect. And when we do the combination of laser, you see that the tumor mass is going coming down. So we can actually do the treatment procedure. So we started getting a feel how we will be operating if it has to be in the clinic at some point. We want to definitely like to see that. So just to ensure, as I was telling you about the design of the PNVCL, so the thermolabile core, and this is what we have been testing in contrast, like in the tube, we unexposed with the laser and exposed with the laser. The PLGA being a lot more stable polymer, it do not go away, and there are of course fractions that we see that are dismantled fractions of the particles. But in case of PNVCL, you see the gold seeds are already washed off, and so the contrast, the electron contrast is lost, and only this disintegrated some material, that is all we could get. And inside the cell also we have done that. The cell, you can see it has burst open, its nuclear membrane is totally lost. And the particles that we could identify within those incubated cells with the laser, they are also very much dismantled type. So these gives us a confirmation that yes, this design of thermolabile core would be an important aspect if we have to think about bringing into the clinic. And this is where the final test, and this is the last piece of data I am going to share you today, is that a very integrated new experiment that we have performed, where a mouse with the material injected and the mouse after material injected laser exposed, and then we are doing ICP-MS. We are checking for the urine and the blood. So urines are collected at different time points, and the bloods were collected at the end time point, and we are measuring. So we are seeing that how, in contrast to the polymer, the PLGA polymer, which is a stable polymer, this PNVCL is coming away through the urine, renally excreted, much faster kinetics within 24 hours. Maximum amount of the gold is actually passed through the urine, came out in the urine sample. So with that, up to this, we have ensured that yes, it can well renally clear. So if I have to just summarize this whole thing, there are multiple aspects that I've talked to. So it's a very simple design of material. So we means the whole scope of the scope of making it a targeted particle and all that, it is absolutely there. So we haven't tapped into all that aspect. We can always do that. But with the simple design of the basic material that we have developed, we see that by combination with the laser, we can have a very nice cancer therapy done, which is highly efficacious. It's a very short duration process, up to 2 to 3 booster, we can consume only up to 30 minutes or so. It is highly biocompatible material. So the constant is like the laser. So it is right now it is limited to the tumors which are palpable. So because you have to excite with the light as well as you have to inject the material. But over the time, once the other form of laser like endoscopic application, we can think about esophageal, lung, and colon carcinomas that can also be approached over the time. And these are some of the other parameters that I have also shown you that shows that excellent precision actually may help reducing the pre-surgical tumor burden with laser toxicity than radiation or chemotherapeutics. So with that note, I must thank the team of the group and the students, particularly Shumit, who works on the AUP-LGA, Shati with the AUP and VCL, and Chetna is also now making other new materials. And the collaborators, Rohit, Preeta, Murli Chilkapati, who is a Raman Spectroscopy person here, Arvind Renagan, who is one of the students from Rohit's lab, now is a faculty in IIT Hyderabad, and Asif Khan as well in INST. And of course, there are clinical collaborators from whom I learned a lot about their procedures, their requirements, and all that, and part of which we have to address in our research. And of course, nothing goes without funding support from TBT and so on. So this is a beautiful place of our institute. Backdrop is this is in the monsoon. Right now it is very dry, but in monsoon this is the look you will naturally get. So I hope I will see you, definitely some of you at some point. And if you are planning to come here, plan in the monsoon, it's a beautiful place to visit. And I'll be looking forward to interact with you. And thank you so much for having me today. I'll be happy to take any questions.
So thank you, Abhijit. We have actually more than 65 participants across the country.
Oh,
we have some questions. So now this session is open for the question and answer. So now
I will start first. I will take the privilege of being in the panel. So just one basic question that have you also seen the effect of this laser on the neighboring cells around the tumors?
Yeah, so the laser, the 650 nanometer laser, 650 milliwatt laser, we have actually tested the laser just on the bare skin itself, just to ensure that this laser is not harmful enough. So, and we have monitored post laser exposure up to different time points like 2, 3, and 4, 5, 6 minutes. And then we left the mouse to identify any scar wound, and histologically also that skin area were cross-checked for any burn wound that the laser has caused. So the laser is really not an harmful entity at all.
Okay, thank you so much. So Dr. Nitai Devnath, who also works on nanoparticle, is asking that normally the SPR peak for the gold nanoparticle is observed around 530 nanometer.
Yes.
And what modifications you have made in the nanomaterial so that it get excited by near NIR light? Right.
So as I was telling you, the design itself. So this is the absorbance peak that you have mentioned is actually the 5 nanometer or 20 nanometer particles. But these are like, there is a core, and then the particles are coated on the cell, on the surface of this core. So now this core to cell ratio, the radius of the core and the radius of the cell, so that determines where it will be tuned to. So the cell ratio, when we change, so that's what makes it to be either fit for 750 or 915 nanometer laser. So by changing the core cell ratio, we can actually tune this to the expected NIR region.
Okay.
Yes.
So another question from Sumishta Das. She is also a nanobiotechnologist in our department. So she is asking, like, for a very ideal photothermal system, it is important that the SPR peak is in the window of biological tissue transparency, which is dependent on size. How to address the agglomeration of gold nanomaterials in physiological milieu for prolonged exposure?
Yes, so 600 above is the tissue window for NIR light. So that is where the NIR tuning is important. And so that's the first thing. And the how the material stays in the okay. So this is you can understand. I'm a biologist and I work in coherence with a material scientist. So it is not coming to my mind readily. Yeah, but yes, they do not precipitate. That is important because we have tested it through tail vein injections. So if it agglomerates, then it will clot actually. So
Okay.
it was ensured, yeah. So and
second
there
part
are
of
these, I think the glycol chitosan and all those different emulsifiers that they have used, so that matters. So yeah, both works are published and full details are in the material design.
Okay. So the second part of the question is similar to my question also, like the physical constraint of laser discharge involves the risk of healthy tissue damage. How to address this issue even with a very small delivery vehicle like gold nanoparticle?
I didn't get the question fully, so can you repeat that again?
So she is asking that physical constraint of the laser discharge involves the risk of healthy tissue damage.
That is for the higher watt.
Yeah.
So our 650 milliwatt is a very low dose X-ray and I mean laser, and that has been thoroughly tested before we actually combined with the nanomaterial.
And how to address this issue when a very smart delivery vehicle like gold nanoparticle is used? So I think you answered.
Yeah.
That.
So basically that is it.
Dr. Pathak, you want to take another questions?
So next question is from our colleague Dr. Janidas Gupta. So she's asking, will combination of PPT with chemotherapy a better option as with PTT alone? Tumor keeps growing, but as a and as a pre-surgery, neoadjuvant therapy.
Yeah, I mean, it's a full option is open. I mean, we can always direct based on the need that the clinicians can cite. So, for example, the core material, that is a polymer, can be loaded with chemo drugs if we want to bring in. So, chemo PTT if we want to do that more, or if we just want to use the pre-surgical offloading of the tumor bulk through PTT. So that is also a possibility, and then the finer surgery would be done for the leftover mass.
So, and next question from Dr. Suresh Kalangi. He is asking about urine clearance of AUNPs out of 125 micrograms. Are we getting few nanograms? Is subcutaneous deposition of AU nanoparticles is observed as they are known common toxic effect?
Gold is not toxic. Gold is inert. Silver is toxic. Silver or platinum could have been toxic, but they are also so. But still, no. We have to ensure that the no accumulation is happening, and if it is through, so the two major route of clearance is either the hepatobiliary system or the renal system, and that is what we wanted to challenge, that our material should get renally cleared. That is the faster clearance route, and if it accumulates in the liver, then what it will actually cause over the period of time. So that's a lot of things to be tested and followed, and then only we can answer that. So that's where actually we tried to, through the design of the material, we wanted to ensure that the renal clearance is happening. And yes, of course, it's a fraction of the thing that we saw over a period of 48 hours. So, but it could have been monitored for a longer time to see the actual urine curve. So how fast? So it is really within 24 hours, and then hopefully there is no second peak coming back. So those kind of things we have to ensure, but this is what we have done so far.
Yeah, number of things is required to doing the pharmacokinetics and metabolic analysis. Yeah.
Actually.
And I'm interested about to learn about if you have to make some kind of actually targeted actually the modification nanoparticle like some folate receptor, a particular some cancer markers. So particularly they will target to only cancer cells rather than the normal cells.
Yes. Yes. Yeah, that is very much possible. And we are, in fact, there are other fractions of the project. We are now exploring all that. So one aspect I very briefly showed you that the folate acid receptor, which is the easiest targeting that we can do against the folate receptors. But there are now peptide targetings and stuff we are doing. Yeah.
Okay. So Dr. Weber is also asking that can this application be used for targeting leukemia stem cells by targeting bone marrow?
Liquid cancer, I think it's a challenge. The challenge is that right now we need a palpable tumor, right? So that is a challenge because you have to get your laser to that tumor site. So it is possible. I mean, over time, like the interventional radiology. So there is one faction of the radiology department. They do the catheter type things through the veins and channels in the body. So you can go to any section, which is what is the practice of interventional radiology. So those kind of laser design has to be done. Right now, the probe that we have, it is only from outside, but we also think that the next evolution can happen for the endoscopic type, which would be the easiest. And then we can access the trachea and the esophageal and colorectal cancers and even cervical cancers and things like that. Yeah.
So Amit, next question from Dr. Devra's, Professor Devra.
So before the treatment, how we will detect and identify the health of the cell? How we will fix the power of the laser? Is it through hookup tables? How the cancer cell structure and molecular bonding change with the environmental conditions?
Okay. Yeah, so we need not to check the health of the cell until and unless we are aim to deliver a targeted nanomaterial. So right now our material, as I showed you, the PLGA, it can through EPR, the enhanced permeability receptor, which is a passive mode of targeting, and that is being used. And in that case, no biomarker is actually required. But if we are having a biomarker targeted particle made, then of course that characterization is important. And there is a second part of the question. What was that? The
second part was how we will fix the power of the laser. It is through hookup table.
The power of the laser is fixed. So there are options for these. So the laser that I showed you, the box that is fixed for 650 milliwatt, but there is also tunable laser power is available where you can, through a button, you can actually set what laser power you want to apply.
So I think no more questions. So
there are two more questions.
Two more questions.
Before we stop. So other was by the Nitai itself that have you done any surface functionalization on gold nanoparticle so that it can be targeted to a specific type of cancer tissue?
Yeah, it is possible. We haven't done as such, but it is possible. Yes.
The last question is, in the most of the recent publications, nanocells are preferred over nano cages, nanorods, and nanospheres for photothermal treatment.
Yes.
Probably It is obviously due to their optical phenomena. But can you put some light over toxicity aspect as well as in terms of histopathological analysis, MTT, or DNA integrity test, if already carried been by your group?
Yeah, so yeah, the nano rod is the one with which the field of PTT started. It is from Georgia Tech. And then there are lots of other structures around gold, different structures that you have mentioned that is people have worked. We particularly choose this nano cage formulation because there is a core, and this core we wanted to make a thermolabile core. So we have designed materials for both thermolabile lipid as well as thermolabile polymer, and the polymer work I shared with you today. And we also have thermolabile lipids. The PTT is also in the clinical trial. So there are several trials that is ongoing in US, and there the core is made up of silica. So now the silica is a very stable molecule, and that's where probably some of these trials has been stopped. But this is where we are going to ensure through the design of these thermolabile core, we are trying to ensure that the toxicity is minimal because it will be cleared faster.
Okay,
So,
yeah, Dr. Pathak, please go ahead.
yeah, so I think no more question. It was very
Okay,
interactive
that's
session.
wonderful. Very good to interact with all of you, and thank you so much.
This is my indeed pleasure to thanks Dr. D for delivering a wonderful talk on a very special day, especially not special, but actually the world has initiated to celebrate this day for February to create the awareness for actually prevention of cancer. So from this talk, many faculty and students and we all getting benefited, and we are very happy to learn about the progress of the cancer research. At least actually this photothermal therapy is showing that at least double actually the life span. So that's a great hope and excellent research. And this is real transnational research. So I wish you good luck and hope better prospect for the cancer research and therapy.
Maybe
So
for
thank you,
future
sir.
collaborations.
Yeah, definitely. So
Absolutely.
we all look your guidance and further
Anytime, yeah.
support to move forward. And although Amity Institute of Biotechnology, we have excellent group and very excellent infrastructure of the research. So
Yeah,
and
I'm sure.
very dynamic people over here, and we will look your support and guidance to move forward.